All right, Red Nation. Today we're going to be talking about scan modes in CT, acquisitions, difference between axial and helical scanning, when you might want to use the different types of helical or axial scanning. Coming up here at How Radiology Works, we have bite-sized content for those interested in radiology. All CT scanning is basically you set up an X-ray tube, the X-rays pass through the patient, they get measured on a detector. You might even have multiple of these on a gantry at one time. But the idea is that you can have motion so that you can scan the whole object. And what we're talking about today is the way in which we can cover the whole anatomy of interest. So depending on your clinical task, you might be interested in covering the heart. So the movies I have today just have a little picture of a heart as place of the patient there. But you might want to cover the brain, the liver, chest, abdomen, pelvis. There are a whole bunch of different types of scan you might be interested in, and for each of them you might want to select the optimal scan type. Today we're going to be talking about the different modes. We're going to start off with basic axial scanning. So I call this axial non-volumetric scanning. This was the bread and butter for many of the early years of CT scanning, and the idea is you go around one full circle of your X-ray source, and your X-ray source is pointed at your detector. This is what we call third generation geometry. So all the pictures that I have here today are of third generation geometry. You can see our videos on first through fifth generation geometry CT to see the difference between those. But third generation geometry is what we've ended up with as the standard of care in modern CT. So regular axial imaging, you get a small coverage when you go around in that circle. Several years ago, in the mid-2000s, there was really what we call the slice wars, where all of the vendors were trying to increase the number of slices on their CT scanners at once. The purpose of today, what I'm going to call axial non-volumetric scanning, is when we have, say, 16 or less rows in the detector. And rows in the detector is really what matters. You can make an arbitrary number of slices in your images. Sometimes the vendors will like to talk about the slices a lot. But for the purpose of today, I was just talking about rows in the detector. Any steps of the table in order to cover the whole anatomy. So what I've shown here in this picture is that you go around in your one full circle, and then you translate. You could either translate the whole gantry on rails, or you can translate the patient table. It's a lot easier to translate the patient table, so typically that's what's done. In order to scan the patient, the table is actually translated, and the gantry is stationary and it's sitting and spinning. In axial, it's just sitting and spinning. You do one full rotation, then you translate, one full rotation, translate, and so on. This is actually good for objects which aren't moving at all. Have a patient which is well strapped in for a neuroscan, for instance. That is an example of an anatomy which isn't moving significantly. But if you're looking at the heart, for instance, doing a scan with this type of acquisition would yield significant artifacts. This was the predominant type of scan before the advent of the slip ring. The advent of the slip ring allowed the CT scanner not to have physical cables winding and unwinding. In the case of a slip ring, the data and the power can be transferred from the rotating to the stationary side of the gantry. In that case, there's now a freedom to have significantly more scan modes than just the regular non-volumetric axial scanning. So this ushered in the era of helical scanning. And in helical scanning, again, you have that table. Instead of just doing one rotation and then moving, one rotation and then moving, you have the table move continuously during your scan. So if you think about the table moving continuously during your scan, it's actually the same thing as thinking about the patient being still and thinking about the detector and source rotating. It just matters what reference frame you're in. But the idea is that as you're going around and rotating, you can think of this source actually tracing out these points on a helix. So that's why we call this helical scanning. When I was in middle school, I learned this shape was actually called a helix, where you're tracing out points on the surface of a cylinder and you're going up continuously. You're moving in what we call the Z direction, or the superior inferior direction of the patient, continuous. Some vendors call it spiral scanning, but the same idea. We're tracing out points on this 3D helix, and the rate at which that table is moving actually is going to control what we call the pitch. So the faster the table's moving, the higher the pitch. And the pitch we actually define as being relative to the size of the detector. So the pitch is defined as the amount of table movement in one rotation divided by the height of the detector. So if you have what we call a pitch of 1, that's what we're showing here. Again, this is just, I'm showing just a sample image of a heart there, but a pitch of 1, the table is going to move the same amount, so that if you kind of project your detector back to the isocenter, that's the distance that the table is going to move during the scan. Pitch 1 scanning is actually relatively common. It's used significantly for angiography, abdominal imaging, and general kind of standard exams in CT. In the case of pitch 0.5, the table is actually translating slower, so that we're getting actually more sampling in this case. In this case, we have more measurements, or what we call redundant data, that we can use in the image reconstruction. This is nice for when we want to have higher spatial resolution in the Z, or the task where you want to have really good reformat quality in the Z direction. You'd want to use a lower pitch like this. And for the task when you actually want to deposit a little bit more dose, you might want to use a case like this. If you want to have the same dose, it's definitely possible that going from pitch 1 to pitch 0.5, you can adjust the MA, adjust the rotation time. So changing from pitch 1 to pitch 0.5 does lead to roughly a factor of 2 dose increase, but you can compensate for that by changing the other factors. Because in the lower pitch scanning, we do have more data that we have measurements of, we can actually use a smoother weighting function when we do our image reconstruction. So it's kind of counterintuitive, but pitch 0.5 scanning actually does typically lead to less motion artifacts than a pitch 1 scanning. Higher pitches, such as a pitch 2, we're showing here. In this case, at the isocenter, we just have enough sampling to make an image, but if we go further out in our display field of view, we actually would start to get artifacts in our imaging if we use a helical pitch of 2, for instance. There's also values that you can do, intermediate, obviously, to pitch 1 and pitch 2, but these are just the limits that I'm talking about here. The reason to do higher pitch scanning is just to cover the object more quickly. It is possible on some modern systems where you have 2 X-ray tubes and 2 detectors to actually use pitches higher than this, because in that case, you can use the extra tube to get that extra sampling. There are modes that are used clinically that have pitches that exceed 3 when you want to have this really fast scanning. These really high pitch scans are used when you want to have really fast scanning, but you're okay with some level of artifacts at the outside of the DFOV. In traditional helical cardiac scanning, it's actually a pitch around 0.2 or less, which is used. So it's a very low pitch helical scan. And the idea of that very low pitch helical scan is that you can do gating so that you can get a given window at one phase of the cardiac cycle. You do it again, you do it again. And this leads to actually a lot of redundant data in typical cardiac scanning. Led to the idea of what was called multi-slab axial or step and shoot scanning. The idea is to have one axial scan, or even using a short scan at one phase, and then move the table, gate the scan at the same phase, so the heart would be at the same position, take another scan, move again, take another scan. So this step and shoot scanning allows you to cover the heart in just 3 or 4 acquisitions, and it's much more dose efficient than a low pitch helical scan. So this is one of the bread and butter imaging modes for standard cardiac scanning. When you have a system which is, say, 64 rows or 4 millimeters of coverage at the isocenter, even if you have a system which is 6 millimeters or 8 millimeters at the isocenter, you're going to be doing this type of acquisition. But in that case, you might just need 2 or 3 acquisitions in order to cover the heart. Finally, we'll talk about wide cone axial. And we're using the term wide cone axial to mean we're going to cover a whole organ. And again, the organ that we're often talking about is the heart, because it's very difficult to image because it's moving quickly. In order to cover the whole heart in just one rotation, the idea is that we would have a detector which is big enough to cover that whole organ. So 160 millimeters of coverage is enough to cover the vast majority of the human heart. There's also some modern scanners using that two-tube, two-detector technology. The patient's heart rate is relatively stable, and you can predict ahead of time where you want to gate the image. You could use a fast, high-pitch acquisition in order to cover the whole heart. In that case, you're going to have a varying phase throughout the heart, but it does allow you to cover the whole heart without that dose penalty of the low pitch helical scan. So depending on the clinical task, you're going to want to set up your protocol to take advantage of the best way to do that type of scanning on the system that you have. And your vendors can work with you to help set up the protocols. There's recommended protocols from each of the vendors, but in general, the idea is that if something isn't moving at all, you can use one of these narrow coverage axial exams. But then outside of that, you're going to want to start to have more coverage, and then your choices either wider coverage axial or wider coverage helical scanning. If you're in the wider coverage helical scanning, it's really good for covering really long ranges because you can just have that moving continuously. And when you need to either deposit more dose or have higher spatial resolution in the Z direction, you might want to go to a lower pitch scanning. When you need it to be very fast, you can go to a higher pitch scanning. And for imaging the heart, when you want to cover the whole heart in just one acquisition, if your heart rate is relatively reliable, you can use a higher pitch scanning mode on a two-tube, two-detector system, or optimally, you can use a wide coverage system where in just one acquisition, you can cover the complete heart. On this system, it also allows you to do gated reconstruction and to change the phase of your reconstruction, because each image that you make of the heart, the entire heart is at the same phase because we were able to acquire the heart and make the images of the heart all consistently at the same phase. Again, all these images, just to make it simpler, I've shown here a flat panel detector. In reality, on a modern CT system, it's going to be an arc or a curve detector. Now you know about the different scan modes, but in order to know the details of third generation CT scanning, that's the basis of this acquisition, check out our video on third generation CT coming up.